Did you say one more person was coming or are they just parking or? I'm not sure. I'm not sure. Oh. Okay. We'll get started. Yeah, there's signs on how to get there, so no big deal. Just tell them to come back down and they can also see it online later. So what you're seeing tonight, well, you can also see it on YouTube later. Because a lot of times you come to something like this and you have questions afterwards, it's kind of nice to see it afterward. But we are very privileged to have Dr. Valerie Swiatkowski here. She's the department chair of obstetrics and gynecology at Catholic Medical Center. Her education was received medical school was at the Wayne State University School of Medicine. And her residency was Women in Infants Hospital of Rhode Island Obstetrics and Gynecology. And she's board certified in obstetrics and gynecology. And she is affiliated with Catholic Medical Center, which has a nice new birthing center within the last 10 years. But I would let her continue and teach you how to prepare for pregnancy, which is very important.
Yeah, thank you so much, Sue.
Closer, you're more than welcome. Do you feel comfortable there?
You said this is the speaker for that person who's online.
Okay.
So I'm okay standing here. Please interrupt at any point if you guys have questions. My goal today was just to kind of put some questions into the slides as food for thought and some basic information. But if there are specific things that you guys wanted to learn about or the things that you have questions about, just interrupt. This is very informal. It's always nice to have slides though, in case people don't have questions. So my goal today was just to review with everybody kind of why is it important to plan for pregnancy and kind of what things should you be thinking about if you have medical problems or if you don't have medical problems to optimize your health for that upcoming pregnancy. And the thought process behind how I kind of think about this when I'm seeing patients is that about 40% of pregnancies in the United States is an unintended pregnancy, which means maybe you're okay with being pregnant, but you hadn't planned it, or maybe it's a little bit earlier than what you had been planning to do. This is down almost 10% from when I was in medical school. So that is a good thing that people are thinking about this and learning how to manage preventing pregnancy or planning pregnancy better than they were when I was in high school, but still we have a ways to go. The reason that it really makes a difference is that when you have an unintended pregnancy, it means that the things that you were doing at the time of conception, you weren't thinking about pregnancy at that time. And so by preventing an unintended pregnancy or kind of planning and being ready at the time of conception, we can have the greatest impact on all of those pregnancy outcomes for each of our moms. Maternal health is kind of a complicated thing, so we're not going to go through all of it because it looks at where you grew up, what area of the country you're living in, what kind of environmental factors go into your environment, including social things, and then lifestyle exposures. It's not just all medical problems. And so we're going to try to touch on some of those things. If you have specific questions about different specific impacts, then we can talk about those too. But if you were in my office and I was talking to you about just general well care, the first question that I typically am going to ask most patients, and then they sometimes will take it by surprise, is would you like to be pregnant in the next year, or when are you planning to have a baby? And this is a question that's important for every patient. It doesn't matter if you are in a relationship with a woman, a man, you're not planning pregnancy now, you already have children. In order to kind of have control over your body, it's important to think about, is this something that I want to do? And then what am I going to intentionally do to either prevent or promote pregnancy? And the way that we go about it kind of is the same, whether your answer is yes or no, to be honest. So the most important thing that you can do to optimize your health in preparing for pregnancy is to optimize your health for lifelong health. So doing well woman care. So when you come into the gynecologist to talk about preparing for pregnancy, what we're looking at are a risk factor reduction for illness. We're looking at weight management, healthy lifestyle choices, menstrual cycle history, and then putting in there all of the things you can do with all of those different parts to be prepared. If you don't want to be pregnant, your answer to the question is, do I want to be pregnant in the next year? No, then we need to talk about pregnancy prevention strategies. And then if your answer is yes, then we're talking about preconception planning and how can you promote and make your body ready for that pregnancy. So kind of the same goals, and we'll go through all of those things. So I broke it down into kind of 4 main questions and how I'm thinking about working with a patient in the office. The first thing that I want to know when I'm getting to know a patient is how healthy are them? Like, what kind of medical problems have they had? Have they had surgery before? Have they had previous pregnancies that had outcomes that were less than desirable? Or did they have very healthy pregnancies before? And how is that going to impact them moving forward in assuming that answer is yes, I want to get pregnant? Do they have any risk factors for any genetic diseases? So looking at their family history and extended family history is important. Do you have any risk factors for current medical disease, even though maybe you haven't been diagnosed with it before? And should we be screening or looking for those diseases? And then do you have any risk factors that could complicate a future pregnancy that maybe you could do interventions for now to make your pregnancy healthier when you get there? So first question, how healthy are you? So most of the medical problems that a patient can have pre-existing before pregnancy can have some impact on how their body goes through pregnancy. But these specific diseases can really make an impact if you do pre-pregnancy planning to reduce your risk. So we'll just go through them briefly so that you kind of have a thought process on how we go about working it up as a doc. For diabetes specifically, one of the main risk factors in a woman that has diabetes before they're pregnant is having high sugar at the time of conception, and when all of the organs are forming for the baby will possibly lead to birth defects. And so we want to, at the time of conception, get the blood sugar as close to normal as we can and have it consistently be normal. That would be ideal. So when you go to your primary care doc, what they're checking to see how your sugar level has been in the last 3 months is something called the hemoglobin A1C level. Levels that are high have been clearly associated with different malformations of the legs and the spine, as well as heart defects. So we work on getting sugar under control, having people understand what the triggers are for high sugar and low sugar, adjusting medications to make sure they're on medications that are safe during that organ forming time of pregnancy. Hopefully all of that stuff is done before they come in with a positive pregnancy test. We don't want a mom to stop her medications when she finds out she's pregnant and then her sugars are all chaotic, because high to low sugars during that early part of pregnancy can increase the risk of miscarriage. And so giving them the information on what to do when they do get the positive pregnancy test really helps them to be better prepared for the nausea, vomiting of pregnancy, and all of those different changes that happen with the metabolism. With high blood pressure, I think one of the main pieces that is important for women of childbearing age is that there are many medications that are used that are really great at controlling blood pressure that can actually impact organ forming for babies. So the different class that's called ACE inhibitors can impair the fetal kidney formation. So we would want a woman that's trying to get pregnant or possibly could become pregnant to not be on medications like that, and hopefully choose medications that are safer for that organ forming time. We get very commonly questions. People will get a positive pregnancy test. They're on a medication that's probably not safest in pregnancy. Then they stop their medication and their blood pressure goes out of control. And so that is less than ideal, right? If your blood pressure is in a very severe or stroke range time at the time when the pregnancy is implanting and starting to grow, that can increase your risk for pregnancy complications and for placenta development and growth. So I would want to try and figure out the medications beforehand, make sure that they're safe, and make sure we have a plan that if you have to be on a medication that's unsafe, if you do have an unplanned or unintended pregnancy, how to safely stop that medication and transition to a different alternative before it becomes a problem. For thyroid disease, we know that low thyroid levels can increase your risk for miscarriage, elevate your blood pressure, and have problems later on in the pregnancy. So for people trying to get pregnant, that risk of miscarriage is probably the thing that's foremost in their mind. What we generally will recommend if you do have symptoms and you're coming in for an annual exam, let's screen you for this, see if this could be a problem, and then make sure that you're on the correct dose and normalize the levels of thyroid hormone in your blood before you start getting pregnant, and try and keep them there during pregnancy. Thyroid hormone replacement, when you do have low thyroid levels, does need to change during pregnancy. We typically have to increase the dose several times just to keep you in a normal level. And so very frequent contact with the endocrinologist and collaborating with the OB is important when you are pregnant. And then moving into postpartum, we adjust the doses back down. For obesity, I think this is one of the things that is a very touchy subject because people generally are pretty concerned about not only their own weight, but how their weight could impact their pregnancy, and both high and low body mass index can affect how a pregnancy is going to grow. Obesity alone can increase the risk for having trouble getting pregnant because it can impair ovulation and quality of ovulation. We know that if you've had recent bariatric surgery, that's the surgery, the kind of stomach stapling surgeries, that can actually cause you to lose weight really fast. So if you did have trouble getting pregnant before, that problem often will go away, and people have a lot of unintended pregnancies in that first 2 years after bariatric surgery. So we need to plan for birth control if you're planning for that surgery. We want to try to wait for you to get pregnant until your weight has stabilized so that you're not having that rapid weight loss while you're trying to grow another human. And then vitamin supplementation after bariatric surgery is also a key piece because you can have malabsorption of vitamins during the time after bariatric surgery. You may need extra supplements while you're trying to get pregnant. Other reproductive risks for obesity, they go from infertility all the way through complications of pregnancy. I'm not going to read all of the different diagnoses for you, but this is one of the reasons why, as an OBGYN, and I'm talking to someone trying to get pregnant, I want to make sure that they, number one, know where their weight is on the range from normal to abnormal, and then give them good, solid information on how to make that risk the least amount for their upcoming pregnancy. For low BMI, these are the women that are a little bit too thin for their height. That can increase their risk for low birth weight infants. And it also can impair ovulation because of the different signals that are required to ovulate. And so trying to keep in that normal range of BMI is important. If you guys don't know what your BMI is and you're trying to figure out where you are in the spectrum, the NIH actually is a really nice calculator, and it will tie into some of the other government sites that I have referenced later on, where it will tell you based on your current height and weight where you're falling in so that you can figure out what your pregnancy risks are. Two other types of issues. We have mood disorders and then we have medication use. So mood disorder kind of falls into both of those categories. So women that have anxiety, depression, especially bipolar, need to be screened while they're at all of their well women visits just to try and make sure that they're connecting into resources. But the key piece that is concerning for me is that if you need medication to keep your mood stable, the last thing I want you to do is stop it because you have an unintended pregnancy. That's going to put you in a spiral that can increase risk for relapse for both the bipolar and for depression. And then it can cause an increase in the amount of panic attacks or anxiety attacks people are having. So we want to have a good plan for if you do have an unintended pregnancy, which medications are safe to continue. If you are up for birth control, which ones are safe to take with your current medications And then what should we be doing? Are there different medications we could be using that might be more appropriate if you're actually trying to get pregnant? Other medications, so depending on which medical problems you may have, like if you're on blood thinners or you have to take seizure medication, any medications for fibromyalgia, pain medications, all of these things may impact, especially in that early couple months of pregnancy when we're trying to avoid medication exposure for birth defects. So each time a woman comes in for her well woman exam, we're going through that medication list to see which medications could be a problem and which, if they're trying to get pregnant, are there safer alternatives? Is this the lowest effective dose for reasonably for your medical issue? You guys doing okay so far? Yeah. Yeah.
Wait, yeah.
No.
Okay, something that shows anxiety and depression that is not, taking medication, otherwise it's, going about for day to day. Does that in itself pose a risk for the development of a fetus? Like having anxiety?
So the question for people online is, does anxiety or depression that's not being treated with medications pose a risk to the fetus? And the short answer is probably yes. And it probably has more to do with not necessarily the disorder that you have with your mood, but the stress response that you have. And so we do know that stress hormones can increase your risk for complications in pregnancy, including miscarriage. And so that makes me worried. I don't want people to come off medicine completely. I think the other things that can put you at risk for are, obviously uncontrolled depression, suicidal ideation, the other social impacts of having uncontrolled disease are really very serious for maternal mental health. So having good control is really important. Other questions? I know I'm whizzing through it because I don't want to not get to anything, but I want you definitely, if you have questions, interrupt. So I wanted a couple of slides just to talk about genetic screening options, because there are different things that you can do pre-pregnancy to see what your risk factors are than what you do during pregnancy, and they're looking for different things. So when you come in, we are kind of thinking about, are there any things in your family that could be tested for ahead of time? And then what would you want to do with that information? There are some carrier screening options that we can do for a lot of different things. I saw a report today for a patient. She had done preconception testing with her and her husband, and they had been tested for over 600 different diseases. So since the Human Genome Project came out, like if there's a disease, you probably can test for it. The question is it actually going to impact your willingness to get pregnant? Is it going to change the management of the pregnancy? Is it going to increase your anxiety to know that you're holding this and there's nothing that you can do about it? Or is it going to help you to know that everything is okay? You don't have something that is in your family. And I have patients go all different ways on that, as far as whether they would want to know or whether they would not want to know. So just kind of go through, there are 3 basic groups of carrier screening. So we're looking at the ethnic, your family history, ethnicity. So we know specifically in groups like Ashkenazi Jewish, there are very high risks for Tay-Sachs and a couple of other diseases that are very common in that specific ethnicity. So we can test mom and dad both to see if they carry those genes, to see if the baby could be at risk for getting that. The expanded carrier screening that I was telling you about with the 200 to 600 different genes, we typically will customize that. We don't do it on every single patient because the chance that you're going to have one of those things that is not probably clinically necessary for you to know is pretty high when you're doing that many tests. The ones that we know and test everybody or offer testing everybody for are cystic fibrosis, spinal muscular atrophy, and sickle cell disease or thalassemias. And the reason that we test and offer for these specifically to everyone there's a very easy test to make sure you do or do not carry it. The disease typically has to be inherited from both mom and dad. So if mom doesn't have it, we don't have to test dad. We know the baby's not going to be affected. And there are very good treatment options that if we have knowledge of that at the time of birth, then the pediatricians can use that information to make sure we're getting early intervention for baby. And so that is going to help you to be able to plan a successful delivery. The customized carrier screening is more for if you have a family history that we've outlined and you want to do testing for that specific disease. If you are marrying somebody who could be like a first or a second degree relative, then it might be more important to do a customized carrier screening to make sure there's not something that both of you could have since you have similar genes. And then kind of going from there. We also will do testing and offer testing once you are pregnant. But that is for kind of random acts of abnormality. So if you have a trisomy, whereas an extra chromosome got into the egg or the sperm, and so now the baby has 3 trisomy 21s, that's what causes Down syndrome. That's not something you inherit because it runs through the family. It's something that just happens in that pregnancy. So you can only test for that kind of problem during pregnancy. Does that make sense? Okay, I didn't want to go too much into genetics because it's kind of overwhelming, but just so you know what you can do. All right, so if we're going to go through, do you have risk factors for medical illness that you haven't known about yet? Like most young women don't see a doctor regularly, and most young men see doctors even less regularly than women. And so when you come in for a preconception visit, our goal is to say, I know you haven't seen a doctor for a while, but could you have something that you just don't know that you have? And that's why we ask you a bajillion questions. So we do both a comprehensive medical history, but we're asking you all of these different symptoms. Have you ever had all of these symptoms? Shortness of breath, chest pain? Do you have trouble walking upstairs? Do you have any headaches? You having weakness, and go through the whole thing to see, should we be testing you for things like diabetes, high blood pressure, all of the different endocrine problems that can happen. I specifically, as a gynecologist, spend a lot more time talking about menstrual and sexual history with my patients than I think most primary care docs do, because that really makes a difference for pre-pregnancy planning. Like, are you going to have trouble getting pregnant? Are you going to need help straight out? And then sexual history can help not only with, you need to know what somebody's sexual preference is to give them preconception counseling, because it's obviously going to be different for someone who's in a same-sex relationship than a heterosexual relationship. And then their response to the exam when we're doing it can make a difference if they've had a history of rape, abuse, they're in a domestic violence situation, like we may need to take a little bit more time explaining the exam and going through the exam, because it can cause PTSD for some patients with that history. And then I got a slide for the next 2 things. So for infection screening, I just pulled in some of the CDC data on the right-hand side and the bottom of this slide. So the things that we typically will test all patients for are the 7 things listed here. What we do is universal screening for anyone doing an infertility workup of all of these different tests. And then universal screening for anyone that is young in their sexual life for gonorrhea, chlamydia, trichomonas, and anyone with risk factors that's older than that. We're trying to do universal screening now for syphilis and people that are coming in for well women, because we did see an uptick in congenital syphilis cases that's been ongoing for the last 12 years. So that is very alarming. We would like to catch syphilis and get rid of it. It's very easy to treat with penicillin before you're pregnant, because you can get rid of it. It's not something that's going to stay in your body. And so if you don't have it when you're conceiving, then the baby won't have congenital syphilis. That's pretty easy. For HIV, we want to test and screen for that, because if you do have it, we want to get your viral load as low as possible before you're trying to get pregnant, and give you some counseling about, if your partner doesn't have HIV and you do, what things you can do to reduce their risk of getting HIV. And hepatitis B and C, same thing, because those are both bloodborne pathogens that can impact your partner as well. For immunization history, there are some immunizations that can be given during pregnancy and are safe for the fetus and actually may benefit the fetus, and some that may have a theoretical risk during pregnancy. And so we pre-screen women for preconception counseling for measles, mumps, rubella vaccination with rubella screening. And then varicella is the scientific name for chickenpox. So if you have either of those are live attenuated vaccines. We would recommend you get the vaccine and then wait a month or two before you get pregnant, just to avoid the theoretical risk that the vaccine could impact the pregnancy growth. HPV vaccine just doesn't have a ton of pregnancy data, so we usually halt the vaccination series once we find out you're pregnant, but there doesn't seem to be a risk. If you had it and then you found out you're pregnant the next month, it doesn't seem to have a risk for the baby. Questions about any of that stuff?
The vaccinations, so, the ones that you can't get or you shouldn't get during pregnancy, are they beneficial to the fetus to get prior?
They are, because if you think measles, mumps, and chickenpox all cause a pretty significant rash and can cause cross the placenta. And so the baby, if you get exposed to chickenpox during pregnancy, can get a very severe rash and have a very higher risk of having developmental delay for all 4 of those diseases. So if you get the vaccine before, then hopefully you can't get it while you're pregnant and the baby will be protected. For the other ones, like the Tdap is for tetanus, diphtheria, and whooping cough, hepatitis B, influenza, respiratory syncytial virus, and COVID. All of those, the vaccine is safe to be given in pregnancy because it doesn't really cross the placenta or have a risk of infection. But it will cause the mom to develop antibodies that can cross the placenta and then protect the baby for all of those infections at the time of birth. But those infections don't necessarily have the same risk of a congenital infection. Does that make sense? Okay. All right, so then we're going in. So we know that you don't have any medical problems. We think that you're relatively have a normal reproductive history. Are there any risk factors for complications of pregnancy that you could alter while you're trying to get pregnant? And so here it's really looking at both lifestyle choices and management of weight, and nutrition are the 3 kind of caveats of what you can do to reduce your risks for complications now in order to plan for that pregnancy in the future. So I think we'll go through each of those in a different slide. So the patients always ask, what should I be doing the months beforehand? The same things that you're doing every day to try and prevent heart disease and heart attacks and strokes and keep your body healthy for longevity. So you want to be eating healthy. If you don't get enough nutrition in your diet, which generally anyone with an American diet has some nutritional deficiencies, taking a prenatal vitamin or a woman's daily will have most of the things you're missing in your diet. Regular exercise, maintaining a healthy weight, avoiding unhealthy substances, and then looking at environmental factors you can alter, all can help you to be ready when that pregnancy happens and make you feel like you're in more control. Specifically looking at tobacco and marijuana, you can see there's a litany of medical problems that have been found in the literature to be associated with tobacco. Marijuana is less well studied, but seems to have a similar risk factor for the pregnancy. And the main things have to do with how the placenta grows and develops, and causing babies to have problems with the growth and the development of the placenta. We also know that women who smoke or live in a house with smoking, the children have an increased risk for asthma, infantile colic, and childhood obesity. So if you can stop smoking pre-pregnancy or during pregnancy and stopping smoking, then your kids are going to have a healthier childhood as well. My sister talks about this all the time. So my mother smoked a pack a day the whole time that we were young. And as soon as she moved out of the house, she didn't have a single ear infection again. She didn't have any signs of infections. Her asthma got better. So all of those things are related to that toxin exposure in the environment. Marijuana also, there's some research looking at the fact that it's a psychogenic medication, that it could alter the wiring of the baby's brain and how the baby brain causes connections. There's less information about that in human trials, but fairly good in animal data. So I think we'll learn more about that now that many more states have legalization of marijuana For men, the specific risk for marijuana is it can reduce your sperm count, and so it can increase your risk of having male factor infertility. So both mom and dad, when you're trying to get pregnant, should stop smoking. For alcohol and other drug use, I think everybody knows this because it's on every bottle of alcohol you ever have read, that there's no safe level of alcohol for use during pregnancy. Fetal alcohol spectrum disorders are what you will see if you're drinking regularly during pregnancy. People will call all the time worried, I just was at a party and I was celebrating someone's graduation or my wedding, and then I found out I'm pregnant 2 weeks later. Probably one episode of binge drinking at a party at the time of conception is not likely going to cause fetal alcohol spectrum. It's more prolonged exposure to drinking. That binge drinking at the time of conception may reduce your ability to stay pregnant or cause miscarriage early in pregnancy. But once you have established the pregnancy, if you've stopped drinking, you probably are going to be okay. So that is one little piece of information. If you get pregnant on your wedding, don't freak out. Just don't drink once you find out you're pregnant. For other recreational drugs, we don't obviously recommend their use during pregnancy, like cocaine, PCP, all of the ecstasy type of medications, because there's not any great benefit to any of those things, and they can increase your risk for placental abruption and high blood pressure. Opioids specifically have a little bit of a caveat, because if you have opioid use disorder and you need to be on medications to transition off, like bupropion or methadone, then we do work with specialists to make sure you're staying on those medications, because relapse is very common if you just stop the medication because of the stress of pregnancy and the way that the disorder works. We'd rather have you be on medications that are safe in pregnancy. A little bit less of a controversial medication, caffeine. People use this all of the time, right, to stay awake. Everybody stops drinking coffee immediately when they find out they're pregnant, and then they have the worst caffeine withdrawal headache of their life. So I wanted to just make sure that everybody knew it is okay. Studies say moderate caffeine consumption, which is less than 200 milligrams per day, is safe. And so that's about 2 cups of coffee or 4 cans of diet soda. So you can still use a little bit of caffeine. Next question people always ask are, what vitamins do you need to support a healthy pregnancy? The one that has the most evidence towards helping prevent the risk of miscarriage and birth defects is folic acid. This is a water-soluble vitamin, which means you have to take it regularly in the right amounts to be able to prevent complications. The USDA recommended value is 400 micrograms per day. That's probably adequate to prevent the type of birth defect that's associated with folic acid deficiency is something called a neural tube defect, which means there's a problem with how the brain or the spinal cord form. So they could be missing their brain, they could have a hole in the spinal cord, or they could have a huge hole down on the bottom part of the spinal cord, which is called spina bifida. So if you take folic acid, it'll reduce that risk. Women that have had a history of that kind of problem, we actually give them 10 times the recommended value of folic acid to try and reduce that risk. And remembering this is water soluble, so your body's going to pee out anything that you don't need. It's not going to accumulate and become toxic. Yep.
When do you recommend start it?
So it is recommended, the question was, when should you start? 2 months before you are trying to get pregnant is recommended. So in women that are not on contraception, or even women on contraception that are willing, I just recommend take a multi, because if you do have an unintended pregnancy, then you're not putting yourself at increased risk for birth defects related to folic acid, and it helps with your strength of your hair and your nails. And so that's a bonus. The other one that you need more of when you are pregnant versus when you're not pregnant is iron. So women that are not pregnant tend to need about 18 milligrams of iron in their diet per day. And pregnancy, you have an increased need because you're growing a whole nother human who needs more iron to build cells, and you need more red blood cells to carry oxygen because your blood volume will expand during pregnancy. So you're doing both of those things. One really great resource that I found is this website. So if you just go on your search engine and put in dietary guidelines for pregnancy, you'll come up with this government website. What it does is it puts in your height, your weight, how active you are, all of these different questions specifically about you, and it will tell you how many calories you need every day, what amount of iron do you need, what type of vitamin supplements do you need, and then it will link into some of the other MyPlate stuff that we're going to have in a couple slides. So I think that was a really good resource because it's going to give you specific guidance for what you need for all of the other vitamins. Because if you look on anything, they're going to say you need a balanced diet. You need all of the recommended daily allowances, specifically looking to make sure you have enough calcium to build bones. You have vitamin A, B, D, all of the other nutrients, including iodine, zinc, magnesium, every single thing that you need to make your body work, the baby is going to need to make their body work. So making sure that you either are getting them in your diet or you're on a multi is going to cover that. So this was that other website that I was telling you about with the patient-specific information from the USDA. And then the other great resource is the myplate.gov website. So this was developed under the leadership of Michelle Obama while Barack Obama was the president, and they used all of the different resources that are out there for healthy eating to try and make it an easy thing. So I think when I was a kid, this is how old I am, and we had this food pyramid that wasn't very easy. This gives you a good visual that if you have a luncheon size plate, you should have 1/4 of the plate have a protein, 1/4 have a whole grain, and then half of your plate should be fruits and vegetables, with more of it being vegetables than fruits, and then using dairy as a supplement. I think that's an easy way for people to utilize it, but it's not the dinner size plate, it's the luncheon size plate is what they use as kind of the model for this particular model. So that would be one thing to just think about. You need a little bit smaller plate. And then the website will go through all of the different choices. They have menus, they have an app that you can download on your phone that will help you do food choices if you're having trouble or struggling on how to get in lean types of meat or what types of vegetables might have enough iron in them, for instance. They have this lovely quiz that you can take, the MyPlate quiz, and it goes through and it tells you where your deficiencies are. And it goes through each of the different food groups and gives you a little bit of education while you're taking the quiz as well. Specific food safety concerns when you are trying to get pregnant that you need to be aware of are things about fish and things about undercooked food. So let's just talk about those two things specifically. So there is a very large body of research saying that fish is very healthy in not only your overall diet, that's the Mediterranean diet, if you've learned about that for healthy eating, but for the development of a baby and the neurologic system, they need the omega-3 fatty acids, the omega-6 fatty acids that are found in fish for brain and nerve development. And so if you're not eating fish at least 3 times a week, then you're not having enough of these different types of fatty acids in, and you should take a supplement of DHA. If you're able to incorporate fish in your diet, it's healthier for your overall long-term health as far as heart health and prevention of heart disease as you're getting older, but also in preparation for pregnancy. So they have a very nice chart that goes through the good fish, the bad fish, and the ones that you absolutely want to avoid at all costs. And talking about when you're looking at a serving of any sort of protein, it's about the size of your palm, if you have an average size hand, or a deck of cards is another thing to think about. If you know that size, that's the size when you're putting on your plate that you should be thinking of as a serving. So a lot of the fish that we eat very commonly are in the best choices category, which is good. I think the one caveat that you should have is if you're catching fish on your own in a lake or in a river, you need to know if there is any concern that there could be a local environmental contamination there. So where I grew up, we had a lake that was very near to the mine that was feeding our whole town's industry. And all of the fish in our area were very highly contaminated with mercury. So we were not able to eat any mercury from the lakes in our area because of that environmental contamination. If you go to the USDA website, they typically will have a listing of all of the different known contaminated areas and which fish to look out for. So you very commonly you'll see catfish, trout, or perch from small local lakes that might have a problem. I grew up in Michigan, not around here, so don't worry about the mercury here. I don't think it's a problem. The other food thing is undercooked foods. So most people will know that if you eat undercooked pork, undercooked eggs, undercooked beef, that those could have foodborne illnesses like salmonella or other types of bacteria that can make you acutely sick. The one that we don't know a ton about, or most people in the community don't know a ton about, is listeria, because in a non-pregnant adult, it usually just causes a mild illness. It's not something you would usually go to the hospital for or get tested for, but it can cross the placenta and it can increase your risk for stillbirth or severe infection of the placenta. So this is the specific bacteria. If you're trying to get pregnant, you want to start thinking about how you're cooking your food and make sure you're eating things that are completely cooked. The things that I think about are on the right. So dairy can be impacted, pate or cold smoked fish, fruits and vegetables, and then deli or ready to eat foods. Like anything that you're not going to take home and cook to appropriate temperature, you need to think this could be possibly contaminated with listeria. So what the CDC recommends to avoid listeria is to make sure if you're choosing milk or dairy products that they've been pasteurized. Unpasteurized cheeses are things like queso fresco, or things that you're getting from an organic farm that haven't been pasteurized. They usually will be able to tell you that if you're buying from a local farmer or farmer's market. If you're eating deli meat like cold cuts, hot dogs, sausages, you need to cook them before you eat them. So that includes bologna. You shouldn't be eating cold bologna when you are pregnant. Choose hard cheeses instead of soft cheeses. That's the next 2 lines or 3 lines. And then any deli salads that are pre-made at the deli. So the coleslaws, the potato salads, all of those salads that you can buy and have them put in a bucket for you to take home. Those, because of how they're made in an area that has multiple different foods, may have small amounts of listeria in them. And so you should instead make your food at home, because then you know that you've used proper food prep techniques. There was a huge outbreak of listeria previously with hummus, because that's not recooked when you take it home, and patients didn't really think about that. You can also, the one that's currently out there is in like pre-made packaged pastas. It's a chicken fettuccine pasta that people aren't cooking all the way when they get home. And then they've had, I think, 20 different people over the last couple months that got very sick from that. As far as fruits and veggies, melons can have listeria in the area that they're being harvested from. And so if you are eating a melon, make sure you wash it. You cut it. If it's been out for 2 hours, you cannot eat it safely. And then if it's in the fridge for more than a week, then you should throw it away. Mushrooms need to be thoroughly cooked if you're pregnant or in early pregnancy. And then sprouts like alfalfa sprouts need to also be cooked, because there's just not any good way to clean those to make sure that they're free of bacteria. Other harmful exposures that people don't always think about are things like plastics and environmental exposures. So the types of plastics that have been shown to increase your risk for pregnancy complications are more those bisphenol A types. So I think most baby bottles and all the plastics will now say that it's BPA free. And so if you're using older plastics, that would be more of a concern. If you're heating up plastic in the microwave, those type of chemicals can leach out into your food unless the dish that you are using says specifically microwave safe. So look for that on your things, or heat your food in glass dishes. You won't have that same problem. Pesticides, lead paint, asbestos, most of those are going to be environmental exposures. If you're in a house that is older than the 1970s and have chipping paint, lead can be a problem. There was a problem, as everybody knows, about now 10 years ago in Flint, where they had old pipes in the houses, and those pipes were leaching lead and causing lead poisoning for children and pregnant women. And that type of poisoning can cause developmental delay and mental retardation moving forward for kids if it's not caught and it's at a high level. So very serious type of problem. Other things, if you are working, do you just want to know what chemicals you're working with? Look up the chemicals you're working with, see if they have an environmental impact. It mostly is going to be solvents, heavy metals, cleaning supplies, and then radiation for like when we work in the hospital, we're doing tons and tons of x-rays, like we need to be careful about that exposure. If you have cats in your house, you should clean the cat litter box with gloves or wash your hands right away after you do it, after you pet your cat, if they're going in and out of the house, because you can have a bacteria that's called toxoplasmosis that can affect the cat litter or cat poop, and that can cause infection for the baby too. All right. You guys doing okay so far? I know. You feel like you're in medical school class, don't you?
So acid for very taking of daily, just general vitamin, and it has it, you have to take a separate supplement that's specifically just folic acid.
So the question online was if you need an extra folic acid above a women's multi, and the answer is no, because almost all women's multis will have at least 400 micrograms, and most prenatal vitamins have 800, so it's like double the dose, but 400 is what you need to prevent the neural tube defects. You're welcome. Other question? All right, we're getting into the last part. So again, promoting healthy pregnancy really requires a healthy human, right? If you're not a healthy mom, then you're going to have a harder time growing a healthy baby. So really focusing on all of those kind of daily activities that you're doing, looking at eating right, making sure you're drinking water, you're sleeping well, you're keeping active, and you're trying to reduce stress. All of those things are going to help to promote your body to have the right metabolism to be able to get pregnant and then stay pregnant. So let's just talk a little bit about movement, because I think people think, and I had this conversation today with a patient, they think they need to exercise in a gym every day in order for it to count as exercise, but the importance of movement is in both parts. So non-exercise movement, which is the scientific word for it is non-exercise activity thermogenesis. It just means you're burning calories by doing normal activities. That is super important for maintaining your metabolism, making sure you're burning the calories that you need and keeping your body healthy. So just thinking about your choices. Are you standing versus sitting? Are you using the stairs? Are you taking the elevator? Do you park close when you go to the store, or do you walk further from farther away? Do you choose to use your dishwasher instead of manually washing your dishes? Doing things like fidgeting, dancing, singing, while you're going about your daily activities can increase your calorie use and increase your muscle tone. And things even as much as sitting up straight versus slouching or lying down when you're watching TV on the couch can make a difference as far as the strength of your spine and your body's ability to be able to handle the extra weight that will come with pregnancy and the posture changes that you will require as your belly gets bigger. So just think about all of those things are very important. If you're working in all of those 6 different areas of movement into your everyday, then you're doing a great job. If you are able to add in actual exercise on top of that, the guidelines for a healthy woman are 30 minutes a day, at least 5 days a week, for a total of 150 minutes of moderate exercise a week. And so that could be walking, running, jogging, swimming. The things that are better for bone health are going to be weight-bearing exercises or weightlifting. Because you're keeping those bones strong and healthy. So if you're trying to do this for a lifelong intervention, like trying to incorporate weightlifting at least 2 times a week can really help keep your bones and muscles strong to prevent osteoporosis when you get older. So that is my little talk about movement. Let's just talk about some of the logistics of how you actually get pregnant and what you need to do to make that happen. Because obviously You need an egg and a sperm to be able to get pregnant. And the sperm needs to be there at the right time for the egg to be fertilized. So in a normal menstrual cycle, the average woman has a 28-day cycle. It could be plus or minus about a week off of that, but the average woman will ovulate somewhere close to day 14. And what happens with ovulation is that the egg is being released from the ovary. So if we're looking at, that's the little white thing hanging off the uterus on the side. The picture over on the right-hand side of the screen is from the ACOG website on how pregnancy occurs. And you see the egg is released and developed on your ovary, but then it has to travel through the fallopian tube, which is that long pink road. It actually will meet up with the sperm somewhere in the middle of the fallopian tube. So you're thinking where the sperm generally is going to be deposited is going to be in the vagina. It has to swim through the cervical mucus, up through the uterus, and into the fallopian tube to find that egg. So it's actually pretty amazing that that can happen. We know that an egg is only good for about a day. 24 hours, and then it's going to die. It's not going to be able to be fertilized anymore, whereas sperm are good for up to 3 days. And so having regular intercourse is going to be really key to making sure that sperm are there at the time that ovulation happens, so you can improve your ability to get pregnant. How are you going to know if you ovulate on day 14 versus day 13 or day 17? Really depends on you knowing your body the best. Because I can tell you what I think based on what you're telling me, but you are going to be able to tell me much better. Because it is going to be, if you could track your period, then I can look at what you're bringing me and I can tell you around where I think the ovulation is going to happen. So the most popular app when you go onto either the Apple Store or the Google Play Store is Flow, but there are some actual tech websites that look at the maneuverability of the different apps, and they have some recommendations on the next page for maybe some more friendly apps. So there are a lot of different choices out there. You just got to find one that you like and that is easy for you to use and understand. What generally you're looking for when you're looking at your menstrual calendar is that if your periods are regular and predictable, then most likely you are ovulating. And so we're just trying to figure out where is your ovulation window. Most women's periods will be from first day to first day, anywhere between every 25 days to every 35 days, and that is in a healthy range. And the average is 28. If your period varies by no more than 3 days from month to month, then you're probably consistently ovulating. If you're varying by more than 3 days from month to month, then you're either not ovulating every month or not or not ovulating at all. And so that would require a workup and us doing a whole lot more of an evaluation in the office. So the options that I found online that had really good ratings for the Femia app, Stardust, Luna, Clue, the Premom. If you want to go totally old school, goodtuesday.com has a free printable menstrual cycle paper that you can print out, and it will go through and you can plot out when your period is to try and figure out when you're ovulating. And typically ovulation in a 28-day cycle is day 14, but if you have a 35-day cycle, it's 14 days before your period starts. So that's why it gets a little bit tricky. You need to know how long your cycle is and then count it back 14 days to figure out when your ovulation probably is going to happen. So then when you're trying to figure out, okay, what is the optimal timing for intercourse? Because the sperm needs to be there. 3 or 4 days before ovulation is when you want to start targeting to make sure that it's happening. If you want to be completely scientific about it, there are apps that will tell you where the window is. There are urine tests that you can do to predict when that ovulation is happening. All of those things tend to add a lot of stress to the whole process. This is supposed to be natural and fun. And so I generally tell people, once you stop having the bleeding from your period, just have sex every other day. And then you'll be covered and you don't need to know what's happening. The sperm will be there. If that is not logistically possible because of your work schedule or your partner's work schedule, then you have to use those other things to really target and make sure that you have the days off or the timing correct in order to increase your rate for pregnancy. If you have had a recent pregnancy, we generally will recommend that you wait at least 6 months to get pregnant. And it's ideal to have at least 18 months between pregnancies for child health. So that is for making sure that your children are able to breastfeed as long as they need to, that they're up and into potty training before you're bringing another mouth to feed into the house. And that has been shown in the worldwide literature to reduce the risk for childhood death. In the US, that's a little bit less important because we don't have as much food scarcity as they do in some countries. For women that are having infertility, we don't tend to wait that long. They're trying to kind of get the pregnancies in before they get too old to get pregnant. And so we do allow them to start doing their infertility treatment before that 18-month time period, but hopefully they're able to wait at least 6 months so that they're able to recover from the pregnancy, the first pregnancy. Then the last question people ask is, when should I worry? I've been trying for a month and I'm not pregnant. Don't worry about it. You think about how miraculous it is that an egg and a sperm have to find each other. Like, it might take you a couple months to get the timing right and make sure that that is happening. And the literature says that if you have no medical problems, you're having regular periods and everything on your well woman checkup worked, give yourself 12 months. Try not to stress out about it because stress can reduce your fecundity, which is your ability to get pregnant. If you're over 35, because you have a shortened time clock for getting pregnant, we typically will start doing infertility workup at 6 months. And then if you're over 40, right away, because that your ability to get pregnant after 40 drops. If you, while I'm talking to you in the office, I find out you have other problems, so your periods aren't normal, your partner has had either the mumps or they have had testicular damage, either of you had chemotherapy or radiation as a child, like all of those things I'm going to work you up sooner for, because if there's something serious, I would rather have you get to the right people than waste time. So that's why we're doing that comprehensive history. And then I just have one last slide, just looking at the effective age, because this freaked me out when I was getting closer to 35. And just to make people realize why they should come in earlier if they're trying to get pregnant after 35, you can see this is a accumulation of a bunch of studies that looked at women that were not using birth control and just how many of them were able to get pregnant at different age groups. And you see how there's this huge drop off in ability to get naturally pregnant between the age of 35 and 45. And generally almost impossible to get pregnant after the age of like 48, 49. So for those women that are older, they need to come in with more timely fashion. So we have more options to help them. And younger women generally have a little bit more time if you want to just wait it out and see if doing some dietary changes or improving your weight will help to improve your fertility. And that was the last slide I had. So, do you guys have any other questions that you want to talk about? Or,
I have a question.
yeah.
Your last slide was titled The Effects of Age and Fertility,
Mm-hmm.
but that is only regarding women.
Yeah.
So what do you have to say about the effects of age on fertility for men?
Oh, that's a good question. So people online, it's what is the effect of fertility for men?
Is it the same or?
Definitely not the same. So for women, we consider them to be advanced age at the age of 35 or older. For men, and we don't worry about that until they're over the age of 55. So they have a much longer time period where they're making good sperm, and even well after 55, have fairly good semen production and function.
Do vaccinations during pregnancy affect when you would give the child vaccinations after the birth?
It can for some of them. So we typically, the newest vaccine that came out a couple of years ago is for the RSV. And that one is typically targeted for elderly people, pregnant women, and children. And so if the purpose of giving it to the woman while she's pregnant is, like I said earlier, like you're making the antibodies to pass to the baby, that's the most effective way for the baby to get immune protection. If you were unable to get that vaccine during pregnancy, then they will recommend for you to do an immune booster, which gives antibodies directly to the baby right after delivery, if they're born during RSV season. So that one changes. The other ones can't be given earlier. So like Tdap usually is going to be at 6 months. Hep B is already offered in the hospital for babies so that they would get that year regardless of whether mom had it during pregnancy or not. So they could get started on that. Flu and COVID are not approved for newborns. And so if you don't get it during pregnancy, then they really are up in a window of not being protected until about 6 months.
Do you know what the impacts, nicotine might have on sperm? Or further than that,
Say that again. What?
nicotine? and
Nicotine?
Sperm,
The main risk for smoking is more for the marijuana related things. So nicotine is more just a concern because of the environmental exposure for smoke for mom and kids for dad than for specific like sperm quality.
thank you.
Mhm.
What is your process for when, you're having to get off for control specifically like the.
So the question was, what is the process for getting off birth control? So it depends on what you're on and how long it might take you to return to fertility. So if you're using an IUD that is really acting locally, as soon as we pull that out, you're going to tend to return to fertility within that first month. And so you can really use an IUD all the way up until the month before you start trying. And then you're good to go. For pill, patch, ring, the shot, the implant, all of those have a little bit more long-term effect on the ovary because you think the way that hormonal birth control works is it prevents you from ovulating. And so your ovary's kind of gone to sleep for the time that you're on it. And it takes women different time periods for the ovary to wake up and be able to listen to the body signals again to start ovulating. And that can take 3 to 6 months. So if you are kind of planning ahead of time and you can use condoms in the time period before you are trying, so you don't get an unintended pregnancy, then you can come off like usually we'll say 3 months before you're starting. But if you feel like condoms wouldn't work or an unintended pregnancy during that time window would be devastating, like you're finishing your master's degree or your husband is in the army and he's going to be overseas, that is less likely because you're going to have not an unintended pregnancy, but you would be out of the window. So like if you're using the pill to treat endometriosis, you're increasing your risk to develop new symptoms while you're waiting for them to come back. Don't do it. It's not worth it. Does that make sense? Okay. Yep.
When do you recommend that the preconception doctor visit is scheduled? Is it the 2-month window before trying or?
So I would come in to talk about it if you're on birth control before you think about stopping it, so that we can talk about why you were on it in the first place and what to expect when you come off. And that really can help you transition a little bit easier. If you are just starting to think about getting pregnant, then I would generally say if you are not, if it's like a premarital thing, come in before you're married, because then we can talk about the genetic testing and would you guys want to know about that ahead of time or what things would be offered. Like that specifically used to be much more important for blood typing, because before we had the medication called Rogam, blood incompatibility was more common. But that's very helpful for the premarital piece. But anytime, like even if you've already started trying and you just have noticed that your periods are a little bit off or there's something else going on, we would much rather have you come in early and us work you through it than have you get worried about it.
How soon after conception should your first doctor's visit be?
If you have risk factors for either recurrent miscarriage or a tubal pregnancy, which is called ectopic pregnancy, then we want you to establish care like right away when you find out that you're pregnant. If everything is going well and you're not having nausea, vomiting, then at the 10 to 12 week mark is when we can start doing genetic tests to look for Down syndrome and do the ultrasound to make sure everything is established well. So that would be kind of the latest time period that I would say. Most people will come in, they find out that they're pregnant about 5 or 6 weeks, and then they come in around 8 weeks.
How busy are offices? Like, how much time do you need in advance to call and make an appointment to then?
That is a great question. It depends on where you're going, and what the appointment is for. So if you are you specifically talking about like preconception or for pregnancy?
Pregnant.
So I would say for preconception, it usually takes a couple months to get in, because that's considered a non-urgent appointment. Most people, if you're having an early pregnancy issue or you're having like nausea, vomiting, you're having bleeding, you can get in within a couple weeks for those type of problems. And for like the true, like, let's talk about genetic testing, first new OB, it could take a couple months to get in for that appointment at some of the offices around here. Some offices will have an appointment sooner. So you just sometimes have to call around a little bit. Best for you to be established as a gynae patient or do the preconception, because then they already know you and they can order all the tests and everything as soon as you find out you're pregnant and if you're worried about anything. Yeah.
You kind of covered vitamins for like mom, but do you have any suggestions for dad?
There are some vitamins that are out there that you can buy that are specifically like targeted at the infertility dad patient. They generally, if you look at them, are the same as a men's multi. And so they're just addressing all of those same like B complex vitamins and vitamins that are important for sperm growth. Mhm. Don't buy the expensive one. Guys have great questions. I'm very excited.
That means you did a great job.
Yeah. I guess the other things that we didn't go through for guys are like, you think for sperm development, the temperature of the testicle is actually pretty important. And so if men have to wear tight fitting clothes for work, important to make sure that they're wearing loose fitting clothes at home. If they're able to switch from briefs to boxers during the time that you're trying to conceive, that can also help because the lower temperature in the testicle will help improve the sperm quality and their ability to swim. So that would be one other thing to think about other than the not smoking and the not smoking or using marijuana. Right. Any questions online?
No.
Okay, perfect.
Well, thank you very much.
Oh,
And
thank you.
always watch it on YouTube. So feel free to find out a lot of that good information again or review it. And even if you don't want to fill out those forms, please, I still read this out. What I'd really like to know is how you find out. And if there's any other programs you would like to